not going to go into it, but none of them really called out to me, except maybe the last one. But finally, after seeing a lot of sunsets, it finally came to me, and also helping Pete out with his Instagram. So I came up with talking about questioning medical dogma. Basically some examples of things other services ask us to do, and the evidence, mostly lack of evidence behind it. So, goals and objectives. I'm going to be giving 4 or 5 examples where evidence contradicts the commonly accepted practice of dogma. And I promised Dr. Willis and Dr. Smith this would be an hour of consultant action. So we'll start off with the case. This is actually Jordan's case. This is actually on the website. It's a nice photo. So Jordan gets an easy sign out from One Medicine Rotators. And I don't know why it's doubled like that. It's basically a 30-year-old male with he's coming in for a right flank pain. The UA shows hematuria but no infection, and the sign out's a follow-up CT. So he gets the CT, and it shows a 9mm stone. It's a pretty large stone with hydronephrosis, and he's like, it's probably not going to pass on its own. Let's call GU. So he calls GU, and they're like really disappointed because they realize the patient has no labs, and he's only had 325 of Tylenol. And that day, Jordan realizes never to trust sign outs. So the exact words from GU were, I was pre-attending and I heard him on the phone. They're like, no freaking fluids, no Flomax, come on, man. So Jordan's really apologetic. He mumbles, oh, this was a sign out to me, sorry. After he gets off the phone, he feels really bad. I tell him, he's like, actually, Flomax and fluids is a little bit controversial. He's like, man, why didn't you tell me that when I was on the phone? So we're going to talk about kidney stones. So what are how hard is it to pass a kidney stone? So there's some data from the American Urology Association, and anything above 46 millimeters, it's 50%. Once you get above 6, you're likely going to get a stent or some type of intervention. And it also kind of goes with stone location. The further down you are, the more likely you are to pass. So let's talk about tamsulosin. So in theory, it should work. So there are a lot of alpha-1 receptors that's concentrated at the distal ureter. So theoretically, it should facilitate stone passage if you give someone an alpha-1 blocker. And a lot of the evidence comes from this systematic review that came out in 2014. That looked at basically 400 articles from multiple databases. They narrowed it down to 5 RCTs, and they looked at stone passage as the primary outcome, and there are a bunch of secondary outcomes, like rate of stone passage, surgical intervention, and hospital admission. And the results they looked pretty good. So the relative risk ratio of stone passage was 1.49. Attributable risk increase was 0.27, which calculates to an NNT of 3.7, which sounds amazing. There are a few medical treatments in the modern era that gives you an NNT of 3.7. So what does this mean? So a little biostats review. A relative risk ratio is basically the probability of an outcome happening in an exposed group versus an unexposed group. This would be a good or bad outcome, like stone passage is good, or death bad. Anything below 1 decreases, the outcome is decreased by the exposure. Anything that equals around 1, it's not affected at all. And relative risk ratio greater than 1 is increased by the exposure. So what does this mean numbers-wise? So if you have a nice table here, on the left side you have patients that received Flomax, and on the right side is patients who didn't receive Flomax. It's kind of looking at stone passages, or if they didn't pass their stone. So how to calculate a relative risk ratio? You basically, it's all off. You look at the percentage of patients who passed on Flomax over the percentage of patients who passed on control, and you get a ratio. The problem with this number is that it can make an intervention look more impactful than it actually is. So, for example, if the passage rate on Flomax was 1.5% and the control is 1.0%. Those are pretty small percentages, but that gives you a nice big number of 1.5. So in this study, the relative risk ratio is 1.49. The authors of the paper interpreted it as, being on tamsulosin put you at a 49% higher risk of stone passage, which sounds like a really, great statement. So that's just why we look at the attributable risk increase in number needed to treat. So the ARI is basically the difference between the probability of an outcome in the exposed group versus the unexposed group, and the NNT is just basically 1 divided by that number. So how do you calculate that? So in this, instead of dividing them, the percentage of Flomax, stone passage on Flomax, which is the percentage of on control, you subtract them. So in theory, if you had someone, hypothetically, if the passage rate on control was only 1%, to get an AR at 0.27, you would need a passage rate of a 28%, which is a pretty good. That makes that is a good number. It makes more. It kind of shows more of how impactful the intervention is. So how they interpreted this in the paper was that the pooled difference was 0.27. In other words, 4 patients would need treatment for 1 patient to realize benefit from alpha blockers. And they broke down the data, and they basically broke it down between small stones and big stones. And the largest, for stones less than 5, they saw no benefit. It wasn't significant. The relative risk ratio actually crossed 1. And for bigger stones, it's actually pretty close to 1 too, but they concluded that there was a modest benefit. And they looked at some secondary outcomes as well, but they mean a little bit less. But these patients had less time to pass their stone. They received less surgical interventions, and they had a lower risk of hospital admission. So basically, the authors supported the use of alpha blockers in the patients with uric stones. So this study had a lot of limitations. None of these, a lot of these studies weren't blinded. They had inconsistent use of post-treatment imaging, and there was a lot of heterogeneity. So patients kind of knew they were on Flomax. The physicians knew they were giving Flomax, so they could decide, who got admitted, who got surgery, and they weren't all ER patients. And so it wasn't a really good study. And a lot of it was, data pulled from papers that were not significant. So it's pretty much not the greatest, paper. So there's a lot of evidence that, if you look within those the 55 RCTs they use, you can actually find, 3 good RCTs that show that, Flomax doesn't really work in stones. So there's one in 2009 that looked at kind of just pain control alone versus pain control and tamsulosin. They found no difference in stone passage. And Picard in 2015, they compared tamsulosin, calcium channel blocker, and placebo at 4 weeks, and there was no difference. And there's one paper published later that compared tamsulosin and placebo, and they showed no difference. And there was maybe a subgroup of people who had large stones that may have benefited, but this was a secondary outcome, and there's no actual dedicated RCT for larger stones. So in July 2018, there was a paper published in JAMA Internal Medicine by Meltzer, and this is the largest RCT done for patients receiving Flomax, and I believe these were patients in the ER. So they asked basic question is tamsulosin effective in facilitating uterine stone expulsion in ER patients? And they looked at only stones less than 9 millimeters in diameter. So this was a nice trial. It was a multi-center, double-blinded, randomized, placebo-controlled study. They gave everyone 0.4 micrograms of tamsulosin daily. Also, the intervention was Flomax. And they split that in half, and the patients had to be 18 and older, and they all had confirmed stones on CT. And the primary outcome was looking at stone passage at 28 days by either the patients seeing the stone come out, or they actually brought in their stone. So the results showed no difference. Took this from Rebel EM. The relative risk ratio of stone passage was 1.05, and the confidence interval was 0.87 to 1.27. So there's a 95% chance the true value lies in between, and it crosses 1. So there's no risk increase of stone passage, and it was insignificant. And they also kind of looked at the data for bigger stones, and there was actually no difference as well, and they actually had a higher pass rate than placebos. And there were also no difference in secondary outcomes, which included pain control, hospitalization, surgical intervention, and repeat ER visits. So there are some limitations to this study. It only included CT confirmed stones, so a lot of patients, got sonoed. The ER physician had a good suspicion that it was a stone, but they didn't end up CTing the patient. So that was there's a large data set that wasn't included in the study. Patients were only enrolled in limited hours of the day, business hours. And there was actually poor adherence to the tamsulosin. So by 2 weeks, only less than about 18% of patients stopped taking their medication, probably because maybe it wasn't helping. And most of the stones they looked at were small. Over 75% were less than 5 millimeters. And a lot of those stones probably would have already passed on their own. So the author concluded, the findings don't really support the use of tamsulosin for symptomatic urinary stones smaller than 9 millimeters, and the guidelines for medical exposure therapy should be revised. So, Flumax doesn't work. What about fluids? This gypsum. So you guys remember this? This was when it was flooded, yeah. So what's the mechanism? What's the proposed mechanism of fluids? So, theoretically, you give fluids, you'll increase the renal output, which will increase hydrostatic ureter pressure and facilitate stone passage. And this, kind of sounds good in theory, but there are limited studies showing that this doesn't work. There's no study showing it does work. So there was a Cochrane review in 2012. Looked at a bunch of studies. They narrowed it down to 2 RCTs, and one was in a Norwegian hospital, and they gave basically one group 3 liters over 6 hours, and one group no fluids at all. And they all got Demerol for pain, and they saw no difference at 6 hours in terms of whether they're going to intervene or not. And they looked at no difference in pain. There was a second study, and in 2006, and they did something very similar. And one group received 2 liters over 4 hours, and one group received 2 mLs per hour of fluids. I don't know why they chose 2 mLs. It's 20 mLs. It's a really small amount of fluid, which is less than 1 shot of alcohol. And they show no difference in stone clearance, hourly pain score, or narcotic requirements. So maybe we're looking in the wrong direction. Maybe fluids and Flumax they don't do anything. Are there any alternative medical therapies we can consider instead? So Miguel actually showed me this paper. He actually sent this to the group a couple of years ago because he was suffered from some. Actually, could I, Dr. Willis? Yeah. I think this converted poorly from Google Slides. Can I just pull up my Google Slides instead? This is missing a lot of.
Yeah.
So.
Good.
There's a nice trick. Yeah, this is. All right, so back. So is there an alternative medical therapy that may help stone passage? Miguel showed me this study that was published in 2015. So they asked, can sexual intercourse, be an alternative for at least distal stones? And briefly go over this one. So what they did was a single-center randomized controlled trial, and they picked 90 dudes, and they actually had a lot of exclusion and inclusion criteria. You had to have an active sexual partner, and you had to have small stones, and you couldn't have any history of erectile dysfunction or diabetes, or you couldn't be septic or an API. And one group was assigned to have sex 3 times per week, at least. And group 2 got Flomex, and group 3 got nothing. And group 2 and group 3 weren't allowed to have sex over a 4-week period. That's they're a little bit in the paper. It was unclear how they enforced that. So the primary outcome was, they looked at stone passage, and this was either declared by the patient or it was seen on X-ray. All the stones had to be radio okay. And what did they find? They found the results look, pretty promising. At 2 weeks, you have an 83% expulsion rate in group 1 versus 47 and 34% in Flomex and placebo. At group 4, at 4 weeks, there's no difference, but probably because most of those stones less than 5 millimeters are going to pass on their own by 4 weeks. And people who were in group 1 in the sex group had a lot less, requirements, visits to the clinic for analgesia, probably because they were too preoccupied. So you crunch the numbers. At 2 weeks, the risk ratio is actually pretty good, 2.41. Number needed treats 2. But it's a very, very select, small patient group. So maybe something.
Besides getting divorced, because it's not with your wife.
So what's the proposed mechanism? So nitric oxide mediates erections. So there's the paper they kind of went over. Maybe the nerves that stimulate the penis also stimulate anal release at the level of the ureter. Which brings up a lot of questions. Does masturbation work as well? Should we consider looking at Viagra or like other medications that potentiate nitric oxide release? Something to think about. Dr. Sitter needs more evidence for research. Try. So basically, conclusions for Flomex fluids and stones. Temsilocin probably doesn't work. Maybe it may benefit for people with larger stones, but there are no dedicated RCTs for this. So it has to be further investigated. And our focus shouldn't be really on medical therapy, but kind of just ultimately a lot of these patients are going to have to follow up and get intervention. Is kind of controlling the pain, make sure they're on a good pain regimen when they go home. And maybe we should consider a sexual exposure therapy instead of medical exposure therapy. All right, case 2. So this is everyone's favorite patient. So we're going to start with a GYN. We're starting with a GYN case. So it's a 27-year-old female, G2P1, she's 7 weeks pregnant, and she's got lower abdominal cramping and vaginal swelling. So we're going to go into the case. It's a rather long one. So you're an intern, it's the year 2016, you have a patient you pick up in 24 hallway, so it's the start of your shift, so you're trying to get her to room 5, and ultimately the room opens up, you get a shot for her, it takes about an hour. Right as you're about to do the pelvic exam, she says, hey, I need to go to the bathroom. She goes back to the bathroom, she comes back, and you go back to room 5, and GYN's in the room, and they're doing a biopsy. So you have to wait another hour. So finally you get through the pelvic, and you're 3 hours into your stay, you find that the os is closed. So you go looking for the sono. This is 3 years ago, so we only have like 2 working sonos. So you go to CCT looking for the sonocyte, and it's being used for a central line. The spark isn't charged, and you go to the pod one's broken, PEDS doesn't have one yet, so it doesn't exist. So this takes another hour to find the ultrasound. So you finally get the ultrasound, and you see something, but you're not quite sure it's an IUP. So your attending, recommends maybe you do a transvaginal ultrasound, and in the back of your mind is like, it's a lot of work. It's probably good for my education. So the bedside transvaginal sono, you finally get the attending, the chaperone, the ultrasound, the probe, and room 5, and this is like 4 hours later, and you finally show an IUP, but there's no heart rate, so you kind of cry on the inside. So she's gonna get a transvaginal, an official sono. So you set her up for sono. She waits another 6 hours. You send off the labs, and she gets the sono, but you don't really have the results. And you get a call from hematology and says, the typing screen's hemolyzed. But in the back of your mind, you're kind of relieved because you had your med students in the typing screen, and you're not sure if she actually, sent on the right patient. So you do it yourself. And the official sono comes back. It's almost shift change. Now it's on 10:45, and it shows an IHP with the fetal heart rate, and the blood test isn't back, and you're like, oh man, the senior that's coming on probably doesn't want sign outs. It's that senior that's probably gonna say maybe the labs will come back after rounds. But finally get a call, and the patient's A negative, and the questions you tell the patient, maybe we recommend giving you a ROGAM. So she's like, no, I've been here 13 hours. Do I really need this shot? I have to go to work at 5. I got kids at home. Do I really need to stay for this? And you're like, I don't really know. So that's what we're gonna go over. So what's alloimmunization? It's basically, this is what ROGAM prevents. So you're pregnant, the fetus is Rh positive, and you're Rh negative. And you create, if there's some exposure, there's some fetal maternal transfusion of blood, you develop antibodies to the blood cells of the fetus. And this doesn't really affect the first pregnancy, but it can affect subsequent pregnancies. And the things they can cause are, there's a wide varying range, but it can go from mild anemia to high drops and stillbirth. And basically, this is what you're preventing. So our ROGAM was basically brought in the 70s, and it greatly reduced this from 3 to 16% down to 0.5 if given postpartum. When given in the second and third trimester, it reduced these rates even lower. So this is a huge scientific breakthrough. It was great. But does this actually work in first trimester, please? Do we need to give this in patients with threatened abortions or spontaneous abortions in the first trimester? And there's one Cochrane review published by Maricopa, 2005, and they did a broad literature search and pretty much didn't find much. There's like one RCT, case control, and a lot of expert opinions. There wasn't much data, but there was one RCT in 1972 that basically had 48 patients who had first trimester miscarriages, and they gave 19 ROGAM and 29 placebo, and no one was sensitized. So this is the only RCT we have. Some other studies that the paper mentioned was this retrospective case control in Mexico, where they kind of looked back on patients who were sensitized, and they saw that no one who had bleeding before 20 weeks became sensitized, whereas greater than 20 weeks in the second trimester, they had 5 times more risk. There's only a single case report of sensitization after first trimester bleed, but that patient got an amniocentesis, which greatly confounds whether the bleed actually causes. Of note, the patient did receive ROGAM during her amniocentesis, but as per the paper, 74% of Rh negative women who receive RhoGAM still can get sensitized from an amniocentesis. And there was one experimental study where they basically injected, a bunch of healthy males who were RH positive with RH negative with RH positive blood, and they saw that only 0.1 mLs was required to sensitize them. And in theory, from another study, the average amount of fetal maternal transfusion at 8 weeks is 0.3 mLs. So in theory, first trimester bleeding should actually sensitize you to RH negative antigen, RH positive antigens. So the author's conclusion was there's no evidence for RhoGAM, at least for threatened abortions, and there's evidence for fetal maternal hemorrhage in the first trimester, but does this actually manifest clinically? We don't know. And there's only one RCT done, and there's probably none that can be undertaken in the future. So what does ACOG say? So on threatened abortions in first trimester, they don't really give any recommendations. So it's kind of a cop-out. And for spontaneous miscarriage, they give it a level C. So, there's not a lot of evidence, but they still recommend it. So what should we offer for RhoGAM in first trimester bleeds? It's hard to say. It's not a cheap medicine.
It says consider, not recommended.
Consider, okay. Fine.
It's a big difference.
Yeah. It's a little, yeah, okay, fine. Thanks, actually. So it's not a cheap medicine. The theoretical risk can be catastrophic, but there's no evidence. So it's something to talk to OB/GYN about. But right now, I think the most common practice is to kind of defer to our local practice guidelines. So on to our third case. So basically, we have a 60-year-old male. He's got a history of AFib. He's non-compliant on his anticoagulation, CHF, diabetes, CKD, and he comes in with diffuse abdominal pain. He has multiple rounds of morphine. He's got blood out of his bottom, and his lactate's 5, and you get some labs. His creatinine has gone up from 1.8 to 2.3. His surgery really wants a CT. You're pushing him to CT, you get a call from radiology. They ask you, the GFR is kind of low. Do you really need IV contrast? So what is contrast-induced nephropathy? So definition is an increase in serum creatinine above 0.3 milligrams per deciliter, or a 50% increase from baseline. This is, that occurs 48 hours of contrast administration. I think this has actually been retermed to be post-contrast AKI because there's, this definition implies causation, and it's never been proven. I'll go over that. So where does this fear come from? It comes from a lot of case reports, observation studies, and they extrapolated it a lot from patients receiving CAS and who were themselves really sick in general, at risk for AKI. Their heart failure, they're having MIs. So there's a lot of confounding bias, and a lot of the studies that that propose the existence of CIM were with high osmolar contrast medias. And if you read Dr. Sinner's EM Docs post, a lot of the patients with repeat serum creatinines were admitted patients, so they were already high-risk patients, and 25% of the admitted patients get AKI, and regardless of whether they get CT or not. So a lot of confounding bias, and when your patients are admitted, they're exposed to a lot of nephrotoxins like NSAIDs, ACE inhibitors, antibiotics, and it goes on. So does it really exist? If you ever read your emails, this is just from this past couple of years. It doesn't exist. So where does this evidence come from? I have 9 papers that that show it doesn't. I'm not going to go into everyone because really this is just to overwhelm you with a lot of text. But there's some good studies. They looked at stroke patients receiving TPA. They looked at trauma patients. They looked at ER patients. These are all retrospective reviews, and there was no difference in AKI. They looked stroke ICU patients and as well as ER patients that were septic, and even the patients that were really sick, there was no correlation between giving IV contrast and AKI. And there are 3 systematic reviews. There's one that has 100,000 patients. Patient, that's a lot. I didn't really go deep into the picture, but it sounds pretty convincing. And they just found no association between giving contrast and AKI. So you kind of convince the radiologist, this patient's really sick. I don't really care what the serum creatinine is. And said, okay, can you make sure the patient gets fluids then before and after? So the question is whether fluids, does prehydration work? This is actually in our kitchen. So there's a trial in 2017 that looked at patients who received fluids and patients who didn't before and after CT. They had 2 different fluid protocols. One was like 1 ml per kg for 12 hours before and after. One group got 3 to 4 mLs per kg for 4 hours before and after. And the mean volume was 1.7 liters. And how can you prevent something that doesn't exist? So this is kind of what it shows. There was no difference. If anything, it put people into acute CHF. So hydration doesn't really work as well. So conclusions. The existence of CIN, it's been overestimated. It probably doesn't exist. Prehydration doesn't work. And by avoiding IV contrast in sick patients, you run the risk of misdiagnosing them, and that this may lead to poor patient outcomes. So don't wait on the serum creatinine issue. If the patient's really sick, you can treat it like a trauma code. Trauma codes, we never wait for the serum creatinine. And read Dr. Sinner's emails. So 4th case. So you have a 10-year-old female who's got no past medical history. She comes in with lethargy and nausea in the setting of URI symptoms. The patient, you get kind of a history. She's had a cough, we used polyuria, polydipsia, and now is not making much urine. Hypotensive tachycardia, looking very dry to you, with completely antikypnic, very clear lungs, and you do a sono. The patient, you see a very hyperdynamic EF with a collapsed IVC. Your junior resident sees the patient and goes, this smells like DKA. And you're like, all right, you just started 2nd year, you can't smell anything. And his finger 650, she's like, oh, I was just testing, I'm just kidding. So you call the PICU, you order the DKA labs, you start the insulin drip, and they recommend giving a 10 cc per kg bolus, and you start a fluid, a rate that's covers a deficit of 5% over 48 hours, and you're like, man, that's not a lot of fluid. 10 cc's per kg to 30 kilogram kids, 300 cc's. That's like 2 cups of apple juice. So in an otherwise sick patient, so you think to yourself, can this child take more fluid? So you call the PICU back, and they're like, well, we don't want to give this kid cerebral edema. So where does this fear of cerebral edema come from? So there are a couple of papers, one from Pediatric Neurology in '99, one published in New England Journal of Medicine that kind of, listed the risk factors that, were associated with cerebral edema and pediatric DKA. And these are retrospective studies, so these can only show association but not causation. So the risk factors they found were, patients who got sodium bicarb, patients with, high serum BON, high because they were really dehydrated, low PCO2 levels, patients who were hyperventilating, patients who had low NA, low serum sodium that wasn't corrected with fluids, or they had, very large drops in serum osmolarity after fluids, low bicarb, and if they were younger, and newly diagnosed diabetes, which is like all of our patients. And lastly, the rate of fluid administration, which I'll talk about. So what's the pathophysiology of cerebral edema? What's the proposed mechanism? So there are 3 theories. One's osmotic. Basically, what the proposed mechanism is in DKA, you have really high osmoles in the serum, and your intracellular osmoles are much smaller. So your brain, kind of compensates by making a lot of osmoles within the cell. And once you give IV fluids, you have this sudden drop in serum osmolarity, and now the intracellular osmoles exceed the serum osmoles, and that pushes fluid into the brain and can theoretically cause cerebral edema. The cytotoxic theory is basically you're dehydrated, you're hyperperfusing, and you're hyperventilating, so you actually have some constriction of your cerebral artery vasculature, and this causes cell death, and all of the protein leakage and everything causes cerebral edema. The last theory is, kind of similar to the previous, to the cytotoxic one. You have a lot of inflammation, metabolites like ketones, and this increases vascular permeability, and which causes protein leakage, and serum fluid leakage is ultimately will lead to cerebral edema. These are all theoretical. This is what I stated before. So there was this recent study, I think this past summer, that kind of looked at fluid infusion rates for kids in DK and if it put them at risk for cerebral edema. And they basically it was a multi-center trial involving 13 hospitals, and they included about almost 1,300 patients with kids between 0 and 18. And some of the exclusion criteria, they couldn't have a GCS less than 11, they couldn't be on drugs or have any head trauma. And they divided them into 4 groups. Half of them got normal saline, half of them got half normal saline, and there were 2 flow rate protocols. The first one actually bolused the kid 20 cc's per kg, which is twice kind of the standard, and they corrected a 10% deficit. Half of the fluid deficit was given over 12 hours with maintenance, and then half of it was given 24 hours. Whereas the slow one was kind of the traditional treatment where you correct for a 5% deficit, they received a 10 cc per kg bolus, and the whole the deficit was corrected over 2 days. They looked also, the primary outcome they looked at was the number of episodes where their GCS was less than 14. And secondary outcomes, they looked for the incidence of clinical brain injury and short-term memory losses, which was kind of measured by how well they can remember numbers forward and backwards. So what they found was basically no difference between any of the groups. There was almost, their ability to recall numbers forward was almost significant, a little bit better in the fast fluid group, but the incidences were dealing with very small percentages. So the author's conclusion was that neither the rate of administration or the type of normal saline given affected, kind of influenced the neurological outcomes in kids with DKA. There are some limitations to this study. There was no blinding of the clinicians. The percentages of brain injury was so low, it's pretty hard to test. And repeat episodes of DK were not excluded. They were a different data point. And they didn't look at other fluids like isolite or LR. And only the patients that were most high risk for cerebral edema only represented a very small percentage of the study population. So the kind of conclusion, association doesn't mean causation. Kids can probably tolerate faster rates of fluids, but so in a child who's hemodynamically unstable, and severely dehydrated, you could probably get more than 10 cc per kg bolus. All right, going to go into the last case, med refill. So you have a 65-year-old male. He's got a history of CHF, EF 25 to 35% from an echo 3 or 4 years ago. He's had one stent placed 4 years ago, hypertension, diabetes, CKD, diverticulosis, and he ran out of his meds, and he's just here for med refill. He's triaged to pot A. When you get more of a history, he's got baseline dysionization, but nothing changed. Some 1+ pitting edema, but he denies any chest pain. I said he's been cath 5 years ago, but it wasn't for an MI. And he's hypertensive because he hasn't been taking any meds. And you do a bedside echo. He has a reduced EF with some B lines, but not up to the APCs. And his EEG is not ischemic. And you think, this guy would be a great OBS candidate. He could follow up tomorrow, but he's got this history of non-compliance, so maybe we'll OBS him and get labs. So you get labs, and you get stuck with a troponin of 0.105, and you're like, damn it. So in your mind, you think, you attribute the troponemia to, maybe 3 months of untreated CHF and hypertension, and maybe worsening kidney function. But you have a pretty low suspicion for acute coronary syndrome because the guy is completely asymptomatic. So he decided to put him in for admission for serial troponins and diuresis. And the med senior strolls around. He goes, does this patient need to be in the CCU? Is this type 1 STEMI? Or is he having a hypertensive emergency? Does he need to be on a nitrogen? And you reassure him, this neither of those things. But he's not listening because this could affect the teams are capped, and this could affect disposition. So he tells you to get a cardiology consult, and you immediately reject getting that troponin or labs in general. And you get a cardiology consult, and they're like, it's unlikely ACS, but get aspirin, Plavix, troponin, start a heparin drip, echo stress test, and a mid-titanium will follow. So you start asking yourself, this patient with a history of a diverticular bleed, does this patient really need to be on anticoagulation? Because you have a nurse in the ER, patients in the ER, nurse has like 12 active patients. This is, managing a heparin drip might be kind of difficult, and we're pretty bad at it. So the answer is, it's no. So if you go to Dr. Z's website, there's a good NNT published by Dr. Sally Yang, and they looked at a systematic review, and they found that no patients benefit long term, and if anything, it makes you bleed, either brain bleeding or GI bleeding. So the number needed to harm was about 17 to 25, and absolutely no one benefited. So what does the AHA say? So they give a level A recommendation for a low molecular weight heparin, and they give a level B for heparin, and this is updated to 2014. So where are they getting this data? So this comes from 6 to 7 papers. It started before we were giving dual antiplatelet therapy and doing a lot of stents, and this was started in the 80s. And this Thoreau looked at patients receiving aspirin, heparin, and placebo, and he found actually there was no difference between treatment and placebo, and if anything, anticoagulation made you bleed. In the risk trial in the 90s, this was a multi-center RCT that also looked at heparin and aspirin. They found that the heparin aspirin group actually decreased the rate of MIs at 5 days, but they found no benefit at 60 days. And there's patients who were on heparin actually had a rebound effect where they had higher rates of MIs down the line once they were off heparin. And Holdwright in '94 found no long-term benefits. Cohen kind of saw the decreased rate of MIs at 2 weeks, but this was kind of, didn't really change after 3 months. Garfunkel in '95 only looked at 7 days, which gave a lot of which decreased MI rates, but didn't look at any long-term benefits. And in '95 in the Fritz trial, same thing. They looked at low molecular weight heparin versus aspirin and placebo, and they showed decreased rates of MI at 6 days and no difference at 150 days. So all these papers showed a short-term benefit, but no long-term benefit. And how the AHA kind of interpreted it was that they showed a strong trend of reduction in composite adverse events. So it's kind of a weird interpretation of this data. It's one way to look at things. So, in 2008, there was a systematic review looking at this. They pretty much looked at the same data and threw it back in the AHA's face, and they, put the RCT together. They include two additional studies, and they showed the primary outcome was mortality, and they showed no long-term benefit. The secondary outcome, they looked at non-fatal heart attack at 7 days, and there is a benefit, but it's with an NNT of 33, but this benefit is totally lost at 1 month and at 3 to 6 months. So, it never really made sense to me to put someone on anticoagulation for 48 hours for someone who already has a clot. In PEs, we give them for like 6 months, and it helps them break down the clot. This is only 48 hours, so to me, this never really made sense. And there was a study actually looking at, the question is whether if the patient's going to get stented, maybe they would benefit from anticoagulation. Because the process of stenting someone causes some local damage to the arteries, and they can make someone prothrombotic. And there's a study done, this one in 2018, in China. So these patients were having legit NSTEMIs. So they looked at patients with NSTEMIs or unstable angina, and they compared. They all received PCIs, and they compared patients who were anticoagulated and not. And they found pretty much no difference in in-hospital stay. If anything, anticoagulation increased bleeding. And the long-term follow-up, which is about 3 years, showed no difference in death. And if anything, anticoagulation increased the rate of bleeding, and this usually occurred within 30 days. So, conclusions, the treat anticoagulation and NSTEMI, heparin is not a benign medication. It's not proven to be life-saving, and there's a theoretical benefit for patients going for stenting, but there's limited evidence. And the benefits of heparin are, if anything, temporizing. And when cardiology is recommending anticoagulation, it's something to talk to the patient about. You could tell them the cardiologists are recommending a medication, but it hasn't been really proven to. It may prevent a heart attack at 7 days, but in the long term, it's not going to change anything. And if anything, it's going to increase your rate of bleeding. You can have a good, nice, shared decision-making conversation with them about that. So back to the case. So the patient is on OBS, and you actually switch rotations, so you get to see him on OBS. He ended up declining anticoagulation, so med senior from CCU, considering CCU, we went back down to OBS. You trend troponins, they're stable. They actually improved with BP control and diuresis, and the patient throughout his entire stay is asymptomatic. He waits 2 days for an official echo, which is unchanged from previous. And you're about to discharge him, and cardiology recommends a 2-day nuclear stress test. And you're like, oh man, can't I just send this guy home? You ask your attending, who says, it's written on the console, we gotta get it. But it's Thursday evening, you never called the nuclear stress test lab to get the isotope for the stress test on Friday, so he won't get the test until Monday. And he's already been on OBS for 6 days. This is actually my patient. So he tells you, I got a dog at home. My friend's been checking him up on him, but I'm not, too confident that they're walking the dogs enough. I got a newborn granddaughter I haven't seen in a long while. And he's constantly reminding me every single day that his long-distance girlfriend is visiting that weekend, and he hasn't gotten laid in a long time. So he wants to freshen up. The person next to him has diarrhea, so he smells like C. diff. So he's going to ask you, do I really need to stay in the hospital for a stress test? And that is for another time. I was going to go into a whole tirade on stress test testing, but there's not enough time. Maybe next year.
That's the colism.
That's the colism, yeah. So take-home points. Always ask why we do things, especially if a consultant who sometimes doesn't even see the patient, recommends it. When a consultant berates you on medical dogma, try to stay cool, because ultimately they might end up taking the patient. And when you're dealing with therapies that may or may not work, it's it's a good idea to actually talk to the patient. And CIN is a total myth. So that pretty much concludes my lecture. I want to give a special thanks to the chiefs for being chiefs. I took a flight from Kenya with Kyle, and he spent 14 hours doing the scheduling, while Pete and I were pounding wine, watching Alien vs. Predator 4 times. So not everyone. Special thanks to the faculty, for sitting through all our lectures. I think it's just taking the day. This stuff is so good. Making sure we get a great education. For the times they put in 12, 16-hour shifts because we didn't have a tenant. Special thanks to them. And special thanks to my class. Every year each class claims that they're the best class ever. For our class, I can confidently say that, we're probably not the best class. No, we're not exactly the friendliest, group of people. No, we're not really good at we're a little bit awkward. And we're not really good at work. This is my first bone reduction in South Africa. This is the floor is on, if I'm not mistaken, the floor is on the left. And on the right is my after reduction. You can actually see Kyle here. He's like, well, that was crap. So I tried like 6 or 7 times. This lady got so much for a set, we had to bag her. But we got it. We got it reduced. I don't have a picture of that though. Besides calling, Jesus, we're not that great at ortho. But we survived a pretty austere environment. We introduced Mon to American culture, and no one got rabies. And if anything to remember, Sarah got us scrubs at UHB. So just one thing to remember from my class. It's been an honor. We turned out okay. We might not be the best. We turned out okay. There's no other group of 24 people I'd rather spend the last 4 years with. And I really, you guys seen this picture a lot, but I really like this picture because you can see, Jesus still has hair. I don't know who this is. I initially thought this was Karen. It's actually Ted's ex-girlfriend. She's etched into history. So Karen's actually here. That's Karen, and that's your future attending. So any questions?